Hello, this is Assessment 2, Neurological Condition on Diabetic Polyneuropathy. Diabetic polyneuropathy, or DPN, is a variety of nerve damage associated with diabetes. Most commonly, distal symmetrical polyneuropathy is a chronic progressive complication of diabetes that affects peripheral nerves. Commonly, there is a pattern of preferential and length-dependent axons that are affected, meaning the extremities are affected first. As the disease progresses, initial changes include thickening of the capillary basement membrane, which correlates closely with neuronal dysfunction. The vasa nervorum are damaged, which are small blood vessels that directly supply peripheral nerves. The polio pathway converts excessive glucose into sorbitol, which decreases the protective antioxidants, leading to increased oxidative stress, ischemia, and a poor compensatory response. Advanced glycation end products, or ACEs, accumulate from hyperglycemia, leading to inflammation and nerve damage. Diabetes also causes DNA damage, endoplasmic reticulum stress, and mitochondrial dysfunction, leading to irreversible cell damage. And lastly, genetic factors are likely involved in the development of DPN, with correlations to family history and specific gene mutations. DPN can affect peripheral nerves, sensory and motor, and the autonomic nervous system. Early signs include tingling and numbness in the feet and hands, predominantly in the feet. Sensory deficits can include reduced vibration and temperature sensations, allodynia, reduced nociception, and proprioception. Light touch is also impaired, and then these all increase the risk of falls and the development of pressure injuries and infection. As the condition progresses, motor symptoms that reflect large fibre nerve involvement, such as weakness, reduced reflexes, muscle atrophy, and gait disturbances may develop. Pedal deformities such as pes cavus and hammer toes may also suggest motor neuropathy. Individuals with DPN experience reduced sensory feedback, which leads to impaired balance, postural regulation, and error correction, which limits effective motor learning. Autonomic nervous system complications are less common, but they can include gastrointestinal problems such as dysphagia, constipation, cardiac issues like hypertension and sinus tachycardia, bladder problems like a weak urinary stream, skin issues like heat intolerance and excessive sweating, and other nervous system complications like carpal tunnel and radiculopathy. 50% of patients with DPN may be asymptomatic despite nerve damage, which highlights the importance for neurological screening, which includes muscle strength, reflexes, sensation, vibration testing, and sharp blunt testing, as well as proprioception testing. People with DPN demonstrate reduced range of motion, joint movements and velocity are also reduced, and proprioception, especially the ankle joint, is reduced. Muscle mass and strength are also diminished. Muscle activation mechanisms are also affected, decreasing peak torques during movement. Normal movement relies on sensory input guiding motor output. DPN disrupt this, leading to slower gait, shortened step, increased double support time, greater variability, and a higher falls risk. Neuroplasticity is compromised in DPN. Cortical reorganization can be maladaptive. Cortical thinning can occur. Gyrification can occur, which is the process that increases the brain's surface area. And these maladaptive processes may lead to chronic pain. Over time, there is a gradual worsening of symptoms. Glucose control effectively slows the progression, more effectively in type 1 diabetes, and the benefit being less pronounced in type 2 diabetes. For treatments, prevention focuses on glucose control and lifestyle modifications. Early identification, patient education, and regular checkups are pivotal. The drugs that work include tricyclic antidepressants, anticonvulsants like gabapentin and pregabalin, and serotonin and norepinephrine reuptake inhibitors like venlafaxine. Exercise like aerobic and resistance training significantly reduce neuropathic symptoms, reduce pain levels, and increase nerve fiber density. Reaction time, static and dynamic balance, and gait quality are also all significantly improved following specific exercise programs targeting these areas and patient deficits. Task-orientated practice uses real-life skills and has been proven to be effective in improving balance, proprioception, and lower limb function. AFOs are also effective for patients with weak dorsiflexors and drop foot. They place the foot in a greater position for muscle activation and reduce the risk of tripping. These are my references, and thank you for listening.